This next lecture is about the pediatric gastrointestinal disorders. The GI system involves an alimentary canal with numerous organs seen in the photo. Because it is so long and diverse, a multitude of disorders can occur. This is either congenital or acquired. And since this system is responsible for our cells' nutrients, any problem can quickly affect other body systems too. And if not adequately treated, it can affect overall health and especially growth and development. Vomiting and diarrhea are common symptoms of GI problems both in children and adults. Box 45.2 also shows other bodily findings in a child with an altered GI function. So these now are the different pediatric GI disorders that we will discuss. First is cleft lip and palate. This is an opening or split in the upper lip, the roof of the mouth, or both. It results from a non-union of the tissue and bone of the upper lip for cleft lip and the hard and soft palate for cleft palate during embryonic development. These birth defects occur when the facial structures that are developing in the unborn do not form properly. Surgical repair is the treatment. Chyloplasty is cleft lip repair. It may be done at 3 months, while palatoplasty is cleft palate repair. This repair may be done at 10 to 12 months. Surgery is important before speech development occurs. At the minimum, one surgery is needed to repair the lip and a separate surgery to repair the palate. However, several surgeries may be needed to make the lip appear as normal as possible. These are the preoperative interventions. These interventions are focused on ensuring proper feeding and nutrition. The other one are the different post-operative interventions. This post-operative care assures establishing the airway, preventing complications such as hemorrhage, and ensuring nutrition as well. Esophageal atresia and tracheoesophageal fistula. Atresia means close, fistula means open. Esophageal atresia is when the esophagus ends in a blind pouch with no entry route to the stomach. Tracheoesophageal fistula, on the other hand, is an open connection between esophagus and trachea. These two birth defects often appear together, resulting from an abnormal intrauterine development. It is not inherited. However, they are often seen when babies have other birth defects such as trisomy 21, diaphragmatic hernia, and some congenital heart diseases. Assessment findings: esophageal atresia, they cannot pass a gastric tube. There's increased drooling and salivation and regurgitation of undigested food. In tracheoesophageal fistula, there is normal swallowing, but some food or mucus may cross fistula, causing choking and cyanosis or aspiration. Stomach may be distended because of inhaled air and aspiration pneumonia from reflux of gastric secretions into trachea. There are several characteristics of the atresia and fistula. These are seen in the 3 photos on the right. Surgery will fix the problem, but while awaiting repair, interventions are focused on ensuring feeding, which is gastrostomy, and prevention of aspirations through esophagostomy. Corrective surgery is through anastomosis, which connects the normal parts together. If there is insufficient tissue for two ends to be attached, a part of the child's colon may be used to connect. Gastroesophageal reflux or GERD is the regurgitation of stomach secretions into the esophagus through the gastroesophageal or cardiac valve. This occurs usually in infants and adolescents because of a relaxed cardiac sphincter or overdistension of stomach by gas or overfeeding. Assessment findings: the vomiting appears effortless, it is not projectile. The child is irritable with some periods of apnea. There are acidic gastric secretions. Among adolescents, they complain of heartburn, usually half hour to 1 hour after meals, and the tests would show less strength of the esophageal sphincter in an esophageal manometry, and fiber optic endoscopy or esophagography with barium swallow shows that the sphincter involved and the reflux of stomach contents into the esophagus are present. This condition may also be associated with the development of esophageal cancer later in life. Management: it's important to feed infants with thickened formula. Position head upright. Give small frequent feedings with adequate burping. Give medications such as ranitidine, omeprazole. This will reduce stomach acid contents irritating esophagus. And if problem does not disappear as the child grows old, a botulinum toxin can be given to temporarily relieve symptoms of obstruction. If all these therapies are ineffective, a laparoscopic or surgical myotomy will narrow the esophageal sphincter so that the GERD will be corrected. All these interventions prevent the reflux of gastric contents and ensure normal passage of foods and fluid down the alimentary canal. Pyloric stenosis. It's the narrowing of the pylorus. It's the lower part of the stomach through which food and other stomach contents pass to enter the small intestines. The incidence of this condition is high, approximately 1 in 150 males and 1 in 750 females. It also tends to occur most frequently in firstborn white male infants. The exact cause is unknown, but multifactorial inheritance is the likely cause. When an infant has pyloric stenosis, the muscles in the pylorus have become enlarged to the point where food is prevented from emptying out of the stomach. Figure 45.3 shows pyloric stenosis where food and fluid is unable to pass easily through the stenosed and hypertrophied pyloric valve. This condition also occurs less frequently in breastfed infants than in formula-fed infants. In formula-fed infants, this typically begin at approximately 4 weeks of age, while in breastfed infants, symptoms begin at about 6 weeks of age. Why? Because the curd of breast milk is smaller than that of cow's milk, so it passes through a hypertrophied muscle more easily. The diagnosis of pyloric stenosis is made primarily from the history. If a child is vomiting or spitting up, be certain to get a full description on its first, duration, which begins at about 6 weeks. Second, intensity. It is usually projectile vomiting. And third, description, which is sour but contains no bile. First, at 4 to 6 weeks of age, the infant begins to vomit almost immediately after each feeding. So again, it is projectile. The vomiting grows increasingly forceful until it becomes projectile, possibly projecting as much as 3 to 4 feet. Second, the vomitus is sour but non-bilous. It's sour because it has reached the stomach and has been in contact with the stomach enzymes. There is no bile because the feeding does not reach the duodenum. Third, children are usually hungry immediately after vomiting. They are not nauseated. There may be signs of excessive drooling or chewing on the tongue as a suggestion that they are hungry. Fourth, they may have signs of dehydration, alkalosis, hypopnea, and electrolyte imbalances, mainly because of the fluid and electrolyte losses, especially when it is not corrected. Treatment. The definitive treatment of pyloric stenosis is surgical or laparoscopic pyloromyotomy, known as Ramsted's procedure. In this procedure, the muscles of the pylorus are divided to open up the gastric outlet. This is a relatively straightforward surgery that can be done through, first, either a single incision, or second, through laparoscopically with several tiny incisions. Surgery must be performed before electrolyte imbalance from the vomiting or hypoglycemia from lack of food occurs. In this scenario, if surgery is performed early, prognosis for infants is excellent. For the surgical correction, the muscles of the pylorus is split down to the mucosa, allowing for a larger lumen. Although the procedure sounds very simple, it is technically difficult, and there is also a high risk of infection afterwards because the abdominal incision is near the diaper area. Omphalocele is a birth defect of the abdominal wall where the neonate's intestines, liver, or other abdominal organs stick outside of the belly through the umbilicus. Usually, it's the intestines who protrude. This occurs as a result of problems in the GI tract development during intrauterine life. As shown in the photo, the organs are covered in a thin, nearly transparent sac that hardly ever is open or broken. Survival rate for omphalocele is about 90%, only if omphalocele is present, but it may be associated also with chromosomal abnormalities and other congenital disorders. Repair is performed in the following ways if omphalocele is small and involves only the intestines. Right after birth, a siloplastic pouch or a mesh type of material is used to contain the organs, the intestines. That pouch or mesh is attached to the baby's abdomen, and every 2 or 3 days or as necessary, the pouch or mesh is gently tightened to push the organs back inside. But if omphalocele is big and involves other organs including liver, an open surgery is needed to place back the protruded organs into its normal anatomic position. The surgeon will then close the opening in the abdominal wall. In this case, in omphalocele, the most common concern is the risk of infection, so nurses must take measures to prevent such complications. Gastroschisis is a birth defect very similar to omphalocele in almost all aspects. As seen in the photo, the protruded organs are also there. The only difference is there is no covering or membrane compared with that of the omphalocele. The cause is generally unknown, but again, it's associated with some genetic conditions and environmental factors during pregnancy. In gastroschisis, risk factors may even include mothers being young and use of alcohol or tobacco during pregnancy. Management is also similar to omphalocele, but there is more or higher risk for infection among those protruded organs. There's a higher risk of infection due to the non-covered abdominal organs. Hiatal hernia is the intermittent protrusion of the stomach up through the esophageal opening in the diaphragm. When this occurs, the volume of the stomach is suddenly restricted. This leads to periodic vomiting similar to that of GERD or gastroesophageal reflux. That is why there is pain with vomiting and shortness of breath. Diagnosis is made through history and ultrasound or barium swallow. These will locate the abnormal anatomical position as shown in the photo. Management: keep the baby in upright position. This will prevent condition from recurring. Second, can administer medications to reduce acid secretions, such as H2 blockers and antacids. If the condition now has not corrected itself by the time the child is 6 months old, even with maintaining an upright position most of the day, laparoscopic surgery is recommended. This will reduce the stomach's ability to protrude through the diaphragm. Inguinal hernia is the protrusion of a section of the bowel into the inguinal ring, seen in the photo. It occurs usually in boys with a 9:1 ratio boys to girls. Among boys, as the testes descend from the abdomen into the scrotum late in fetal life, a fold of peritoneum also descends. This forms a tube from the abdomen to the scrotum. In most boys, this tube closes completely. But if it fails to close, the intestines may descend at any time when there is increased intra-abdominal pressure. In girls, the round ligament extends from the uterus into the inguinal canal to its attachment on the abdominal wall. An inguinal hernia may occur because of a weakness in this muscle surrounding the round ligament in girls. Assessment findings: it appears as a lump in left or right groin. This is very apparent when the child is crying and with increased activity, as when intra or abdominal pressure increases. Also, inguinal hernia is generally painless. A painful inguinal hernia means that the intestines have been confined in the sac. This requires immediate action or surgery to prevent bowel obstruction and ischemia. Treatment of inguinal hernia is laparoscopy surgery. The bowel is returned to the abdominal cavity and retained there by sealing the inguinal ring. Before, surgery for inguinal hernia is delayed until 3 or 4 years of age. But today, to prevent bowel strangulation, which is a surgical emergency, infants with inguinal hernia may have surgery before 1 year of age. Surgery can also be proposed as a prophylactic measure. In this case, parents must weigh the value of surgical repair against the risk of anesthesia and surgery in their child. After surgery, it's important to keep the suture line dry and free of urine or feces to prevent infection. Infant will need frequent diaper changes and good diaper area care. Also, assess circulation in the leg on the side of the surgical repair to be certain that edema of the groin is not compressing the blood vessels. This will assure that there is no obstruction or obstructing blood flow to the legs. Appendicitis is inflammation of the appendix which prevents mucus from passing into the cecum. It's the most common cause of abdominal surgery in children. The appendix, as a review and shown in the photo, is a blind end pouch attached to the cecum. It may become inflamed because of an upper respiratory or other body infections. What happens? In most instances, aside from infections, fecal material apparently enters the appendix. This hardens and obstructs the appendiceal lumen. Inflammation edema will develop, and this leads to compression of blood vessels and even cellular malnutrition. Necrosis and pain will then result. That's when children will manifest the signs and symptoms. If the condition is not discovered early enough, the necrotic area will rupture and fecal material will spill into the abdomen, causing peritonitis, a potentially fatal condition. That's why in appendicitis, we do not wait for it to rupture. The following are the assessment findings in appendicitis. Among all these findings, the localized pain distinguishes appendicitis from that of acute gastroenteritis. The abdominal pain in appendicitis usually starts diffuse, but gradually it localizes to the right lower quadrant. The point of sharpest pain is often 1/3 of the way between the anterior superior iliac crest and the umbilicus. This is called the McBurney's point. Diagnostic tests because of inflammation, WBC increases at 10,000 to 18,000 per cubic millimeters. There's elevated alcohol or ketone in urine as a symptom of starvation from poor absorption of the intestines. The ultrasound or CT scan also reveals the swollen appendix. Management: administer antipyretics or analgesics as ordered. This will manage the pain. No edema or heating pads. These may perforate the appendix and may possibly cause internal bleeding. Third, therapy is through appendectomy by laparoscopy. This must be done before the appendix ruptures. Post-operatively, nurses should monitor drains which were placed during surgery. Warm soaks to the incision line may be ordered 3 or 4 times a day to encourage more drainage. It's important to examine the wound carefully at each dressing change. Be certain also not to dislodge drains while removing soiled dressings. But if the appendix has already ruptured, it is important to monitor for peritonitis. Generally, the children appear severely ill, and WBC rises to more than 20,000 per cubic millimeters. It's important to position semi-foulers so that the infected drainage from the cecum will flow down instead of going to the lungs. Second, administer IV fluid for hydration. And third, start antibiotics pre-operatively. Because peritonitis is the potential danger, watch out for its signs. It includes rigid abdomen, shallow respirations, and increased temperature. Celiac disease is a sensitivity or abnormal immunologic response to protein, particularly the gluten factor in grains such as wheat, rye, oats, and barley. When a child ingests gluten, damage occurs in the small intestines. This interferes with absorption of nutrients from food because the intestine's main function is absorption. This disease is both a disease of malabsorption, meaning nutrients are not absorbed properly, and it's also a disease of an abnormal immune reaction because these children cannot tolerate gluten. Assessment findings include abdominal bloating and pain, chronic diarrhea, vomiting, pale, foul-smelling or fatty stool, and weight loss. All these GI findings are because of the immune reaction to gluten, causing malabsorption of nutrients. These are noticeable between 6 to 18 months of age. Diagnosis: serum analysis of antibody against gluten shows IgA antibodies. Biopsy of the intestines show typical changes in the intestinal villi. Oral glucose tolerance tests will reveal poor absorption, and stool may be collected to test for fat content, which is increased. The only treatment for celiac disease is a gluten-free diet. To stay well, children with celiac disease must avoid gluten for the rest of their lives. In the photo, it shows a variety of foods to be avoided in celiac disease. This includes breads, cakes, cereals, pasta, dairy products, and even alcoholic beverages. Also, it's important to administer water-soluble forms of vitamins A and D, as well as iron and folate to correct anemia. Hirschsprung's disease is also a ganglionic megacolon. It is the absence of ganglion cells in a section of the bowel, usually in the lower portion of the sigmoid colon just above the anus. This is caused by an abnormal gene on chromosome 10. The absence of these nerve cells mean that there are no peristaltic waves in this section of the bowel. So, movement of fecal material through that segment of intestine is impossible. It's common in males, and incidence is 1 in 5,000 live births. Assessment findings: because the newborn stool is generally soft, symptoms do not show until 6 to 12 months. However, if extensive section is involved, even meconium at birth cannot pass. So there is chronic constipation, ribbon-like stools as the stool passes through a small narrow segment with no ganglion cells, and the portion of bowel proximal to obstruction dilates, so the abdomen becomes distended. The photo shows that the distal part of the bowel lacks nerve innervation because of the absence of the ganglion cells. And because there is no peristalsis in this area, the bowel proximal to it distends. Treatment consists of surgical removal or resection of the abnormal section of the colon, followed by reanastomosis. There are 2 steps to achieve this goal. First stage is through a colostomy. This temporarily allows bowel contents to be discharged outside in a bag. This is while awaiting surgery. With colostomy, the large intestine is cut off and an opening is made through the abdomen. Again, this allows the bowel contents to be discharged into a bag. Later on, when the child's weight, age, and condition is right, this is usually at 12 to 18 months, a pull-through procedure is performed. This procedure involves dissection and removal of the affected intestine with anastomosis or connecting of the involved bowel. This will correct the condition. Kwashiorkor is a disease or a malnutrition caused by protein deficiency. This usually occurs after weaning the child, when they change from breast milk to a diet consisting mainly of carbohydrates. Hypoproteinemia occurs most frequently in children ages 1 to 3 years old because this age group requires a high protein intake mainly because of growth and development needs. Assessment findings: growth failure. This is a major symptom. Children fall behind other children of the same age, also in terms of motor development. Second is edema. Edema results from the hypoproteinemia. This causes a shift of body fluid from the intravascular to the interstitial space. This causes ascites, as shown in the photo. The edema also tends to be dependent, so it is first noted in the lower extremities. Third is severe wasting of muscles. This is masked by edema, so they may not appear light in weight until the edema is relieved. 4. They are generally irritable. The children are uninterested in their surroundings. 5th, there is a zebra sign. Hair shafts with striped appearance of brown and white. That's the zebra sign. This shows a period of good protein intake, then poor protein intake, then good protein intake again, and so on and so forth. 6. They may have diarrhea, iron deficiency anemia, and enlarged liver. These conditions will compound the problem. Without treatment, Kwashiorkor is fatal. As a therapy, a diet rich in protein is very essential. However, even if corrected later on, this may still result in failure of children to reach their full potential of intellectual and psychological development. Marasmus is also a malnutrition caused by a deficiency of all food groups. This is basically a form of starvation. These children are most common younger than 1 year. Although common in developing countries where food supplies are short, it can also be seen in grossly neglected children or those with failure to thrive. They may have the same symptoms as children with Kwashiorkor, including growth failure, muscle wasting, irritability, iron deficiency anemia, and diarrhea. While children with Kwashiorkor are anorectic, these children with marasmus are invariably hungry. They starve. They may suck at any object such as finger or clothing. Treatment is a diet rich in all nutrients.